I'm Brad Power, and today we're going to have a session with Nigel Brockton talking about the research on lifestyle, nutrition, exercise, and so on, and how it can help in cancer treatment. But before we do that, I want to read our standard disclaimer so that everyone knows that this is not medical advice and that this will be, if you say anything, if you have your camera on, it all will be made public in a Zoom recording and in a transcript. Please note that the information and opinions shared on this website or platform or during this discussion or presentations are not intended as medical advice. It is important to consult with a healthcare professional about your specific situation before making any decisions related to your health. Which I like to point out is that's a ChatGPT version, for those of you who know about ChatGPT, which took the legal words and made them a little more simple and clear. And with that, I'll turn it over to Nigel, who's going to lead a discussion today. He's going to start with a few slides, and then we'll open it up for discussion, and we'll finish in an hour.
Okay. So I realized, sorry, I need to share my screen before I open the PowerPoint.
Oh, and Nigel, if you could start by also introducing yourself, and the story you started telling me would be perfect. I don't know if it's in your slides, but it's
not in my slides, but I'm happy to.
Yeah, please do that. I mean, one of the things we found, and I'll just mention, there's someone named Wendy Fantel, who's an ovarian cancer survivor, who's a scientist at Stanford. When we find people who are cancer survivors themselves, it really gives them a special perspective on consistent with who we are and what we're up to.
Okay. Can you see my slides?
Yes.
Yeah.
Perfect.
So thank you for inviting me. I realize there's a slight incongruity between my title and what I'll talk about, because the blurb that we put together, talking more about the post-diagnosis space. Happy to talk about that. And what I'm going to go through in these slides is more just how we arrive at the evidence. So I'm Nigel Brockton, Vice President of Research at the American Institute for Cancer Research. Brad was asking me how I got into this line of work before we went live. I was 8 years old when I decided I wanted to be a marine biologist. I stuck with that single-mindedly until I had a degree in marine biology. But on the way to getting a degree in marine biology at 18, I was diagnosed with a Ewing sarcoma in the soft tissue of my jaw. That side. This was in 1989, when there was zero information about cancer. In fact, people wouldn't even say the word cancer. And it's quite amazing the societal change in that I've sort of lived through. And even between 1989 and 1992, when I had my recurrence, people had started to be able to say the word cancer, but still I was working in a bar or a sort of English pub, and I was reading a book on chemotherapy. It was and in those days there were no layperson books, so this was a book for doctors, and somebody asked me to put the book away because it had the word cancer on it. So I think the fact that we have these forums to have these kind of discussions in this day and age, and almost too much information, which is one of the roles for AICR, to cut through to what we actually know. There's been some pretty massive changes. So I had a recurrence. I went through 9 months of intensive treatment, and I've been cancer-free since I finished treatment in February, March of 1993. So actually this will be 30 years next month. And I get that look from oncologists when I tell them that I had a Ewing's and a recurrence, and I get that look of like, what the hell are you doing here? Because there are very few recurrent Ewing sarcoma survivors. So yeah, let's get into this. So I have no disclosures to report. For those of you, I don't who's familiar with the American Institute for Cancer Research before I popped on your radar? Anyone show hands? No. Good. That means I'm talking to a new audience and sharing our message. I've been following AICR since I started my PhD in 1997, when the first expert report was published. And certainly from a research and clinical perspective, AICR, WCRF are seen as the global experts on diet, nutrition, physical activity, and cancer prevention and survival. Not sure how many of you followed this back in February when they relaunched the Cancer Moonshot. And I was pretty frustrated. I mean, I'm totally supportive of the moonshot, but I was pretty frustrated when President Biden said, we know cancer is a disease that we have few good ways to prevent. And part of what I'm going to present here is that we have lots of ways to prevent it, actually. A little bit of a history or contextual situation in terms of AICR are 40 years old, or were 40 years old in 2022. And the way we think about cancer has changed dramatically over that period. I mean, when people were looking at the causes of cancer, it was in the 1980s, it was all about external carcinogens. So even when people were talking about diet, it was like, what are the carcinogens in our diet? And then when that research didn't really pan out as expected, it was, well, maybe it's the enzymes and how we activate these carcinogens. And there was some progress on that front, some mechanistic insights. But then really, as we got into the 2000s, it was more looking at metabolic factors and endogenous factors, obesity, inflammation, became the driving kind of etiologic, the causative factors that people were looking at. And now, as we move into the 2010s, or as we move through the 2010s, it was the host and the microbiome and the metabolism. And now, we really are in the era of immune responses and interplay with tumors, which prostate is a particular issue in that regard. How we think about diet has changed. It was all about single nutrients in these magic bullets. I'm sure you've heard the beta carotene story. My mother was duly giving me beta carotene tablets when I was going through treatment because, well-meaning, but that's what people thought was going to be anti-cancer, and in lung cancer, it actually increased the risk of lung cancer in smokers. Then it was looking at, well, maybe it's the genes that regulate and metabolize these nutrients. And then as we got into the 2000s, it was really looking more at whole foods and dietary patterns, and there's a big interest now on sort of time of eating. So not just what you eat, but how and when you eat. And back in the 1980s, when the first lifestyle recommendations were released from AICR, there was quite a lot of pushback, and we were seen as snake oil salesmen, and this was, nothing you could do personally was likely to be effective in cancer prevention. Then we moved to strong evidence into the 2000s. I mean, the first expert report was in 1997. That summarized the evidence and made some conclusions, but really strong evidence in the 2000s. And then since the early 2010s, actually showing the research showing the benefits of adhering to the recommendations, and now the application of those recommendations and the evidence to support benefits in survivorship, both in quality of life and survivorship. So basically, the reason that AICR were formed was to try and distinguish evidence from opinion, because the consumer is, and fatigued and confused by the changing messages. And this is just one example that I picked out of, 1 week oatmeal is bad for you, the next is good for you, and what is the consumer meant to do? So distinguishing evidence from opinion, summarizing all the evidence. And this is a very busy slide, but just to give you an idea of the printed summary, as we call it, of the third expert report is 160, I'm just grabbing one here, 116 pages. We used to have these reports that were 400 or 500 pages, the first two. The second one came with a CD-ROM at the age that we're living in then, with the systematic literature reviews. But there is a massive amount of information that is distilled down into usable recommendations. Everything starts with a protocol. So if you look at the top here, these are the protocols that, rather than just going in and analyzing the literature and frankly looking for what you want to find, this is describing what you want to do before you start, then doing all the systematic literature reviews. So the prostate cancer literature review, oh no, I didn't mean to do that. I was trying to cheat and look at my, I can't remember how long the prostate cancer literature review is. I know the breast one is 2,000 pages and the breast cancer report is 200 pages. So the systematic literature reviews where we take all of the evidence from around the world and meta-analyze it. I'm not sure if people are familiar. That's a sort of quantitative way to assess the evidence. If there's not enough studies or they're not compatible enough, then they're just narratively summarized. We take all of that together. The highlights of those systematic literature reviews go into the CUP reports, continuous update project, which is now changed to the Cancer Update Program, but keep the acronym. And all of this got updated in 2018 for the third expert report. There are exposure chapters, so you can go through, if you're interested in a particular exposure, you can find it in there. If particular exposures are not in the exposure chapters, they will be in the SLRs. So all of this is available online. It is a massive, in total, it's about 12,000 pages of information. But have I got my funnel? No, I like to think of it as a funnel where you have the SLRs, which is all of the information in the gory details, the CUP reports, which kind of take those highlights, and then the summary, which is what it says. It summarizes all that information across all of the cancers, and then we have our recommendations.
What is SLR?
Systematic literature review. So up until 2018, 1997 first expert report, the evidence was pretty embryonic at that stage. In the next 10 years was a lot more research, a lot higher quality research, and a much better process was put into very uniformly assess that evidence. And then that process was used in the third expert report in 2018. And at the point of the 2018 report being published, internally, we had a meeting beforehand and we presented the recommendations. And people were actually a bit disappointed that they weren't that different from before. And I was like, well, that's good, because that shows we've been on the right track and that the things that we're talking about are actually effective. And, it would be fairly, especially now, it would be fairly easy to criticize the quality of the research in 1997. But, it came up with pretty good conclusions that have stood the test of time. Better evidence in 2007, slight changes to the recommendations, but nothing major. And the same, so we know really the factors that are in a lot of cancers, not all, that can contribute to reducing risk. So what do we actually know? And again, this is, for the moment, this is focusing on all cancers. This is I'm trying to move my panel. Oh, there we go. This is a strong evidence matrix. So I like to use the two examples here of colorectal cancer, where we have 10 factors that we know change your risk. So 5 over here that decrease your risk of colorectal cancer, 5 over here that increase your risk of colorectal cancer. Adult attained height, where is it? Here. Is a risk factor across many cancers, but there's not much you can do about it. Adult body fatness is another one, and with the obesity epidemic is increasingly important. But so there's a lot you can do to reduce your risk of colorectal cancer. For prostate cancer, we have, the foods that contain beta carotene, that is actually, I don't know if you can see the key at the bottom here. It says substantial effect on risk unlikely. So although there are concerns in lung cancer, there's a lot of research done on prostate cancer, and beta carotene is not a risk factor for, and this is actually a strong evidence conclusion. So for prostate cancer, we really only have adult body fatness, and that is specifically for advanced prostate cancer. Because of the issues of overdiagnosis with PSA testing, there was a bit of a wash of the epidemiologic evidence, and a lot of this can only actually be done. Advanced prostate cancer was defined as either fatal, which is obviously post hoc, or higher stage. So in terms of prostate cancer risk, there is limited suggestive evidence that dairy products, diets high in calcium, and that's probably how the dairy products are operating. Diets low in plasma alpha tocopherol, but you'll see we don't recommend supplementing with these. It's just if there are diets that are specifically low, and then there's limited suggestive evidence. And then there are all these limited no conclusion, where there's been a lot of research on these, but just it's not strong enough to make any recommendations. And the two things that we do know increase risk are body fatness and adult attained height. Oh, this is similar to the one before.
Can you talk about what adult attained height means here? Or
well, so taller people tend to be at higher risk of cancer, and that's seen pretty much across all cancers, and is believed to be due to genetic factors. Just taller people have more growth of cells. Cancer is basically the growth of cells. It may be a marker of nutritional status. It's just it's not something we can do anything about. We wouldn't want to stunt people's growth. But if you were trying to sort of assess your risk of cancer at baseline, based on your lifestyle and your anthropometry, height would be in there as a factor. Does that answer the question?
Yeah, it does. By the way, I'm 5'6", so pretty short.
Yeah, these things are all probabilities, and I'll talk. I've got an analogy for that at the end. So this is
kidding.
This is looking at not just the strong evidence, but also the probable and limited. So that's why you've got dairy and calcium in here, low plasma, so all the things that were in that last matrix. So, but you'll see for some exposures, so the exposures are along the top and the cancers are down the side, we have a lot of information, but there's a lot of gaps in here, and some of that is there's just not enough evidence, or it just hasn't even been looked at. So these are our recommendations: be a healthy weight, be physically active, eat a diet rich in whole grains, vegetables, fruits, and beans, limit consumption of fast and processed foods, limit consumption of red and processed meat, limit consumption of sugar-sweetened drinks, limit alcohol consumption, don't use supplements for cancer prevention. For mothers, breastfeed your baby if you can, and after a cancer diagnosis, follow the recommendations if you can. So we don't have specific survivorship recommendations, but all of these are likely to have a beneficial, well, I mean, breastfeeding is not relevant to prostate cancer, but all of these are likely to have a beneficial impact on survival, reduction of second primaries, and other chronic diseases. So, and obviously not smoking and avoiding exposure to sun or excess sun. So it does say follow recommendations if you can, and to have that discussion with your healthcare provider. In terms of supplements, there are reasons to take supplements. It's just that cancer prevention isn't one of them, and we don't have strong evidence in the survivorship setting yet either. I like this comment by our nutrition advisor, Karen Collins. It's a call for action, not perfection. And what we see is that the more of these people meet, the better their, the lower their cancer risk and the better their outcomes. But any of these you could address will be beneficial. So this is actually the breast cancer analysis in survivorship that we just did, published in October. We've just done colorectal cancer. The next one is actually childhood cancer or childhood leukemia. And then we're doing prostate cancer. So there will be this kind of synthesis. And this is looking at these different outcomes along the top. So all-cause mortality, this breast cancer mortality, breast cancer recurrence, second primary, non-breast cancer mortality, and cardiovascular mortality. So looking at all of these outcomes with all of the exposures that sort of summarize lifestyle. As you can see, a lot of gaps in here, but body mass, or body fatness, basically using BMI as the surrogate, is where the strongest evidence is for breast. And there are a lot of parallels actually between breast and prostate cancer. So it's kind of watch this space in terms of us being able to come up with something that is analogous to this in prostate cancer. So coming back to the probability thing, this is my last slide before we can have a discussion. I'm not sure if anyone's aware of the cancer lottery analogy, and I'd used it for many years, that cancer is like the lottery that you don't want to win. And we're all born with at least one cancer lottery ticket. If you have a predisposition, then you may be born with many. It doesn't mean you're going to get cancer, but for each of the unhealthy lifestyle factors that you adopt, you're basically buying cancer lottery tickets. So I'd used that analogy for years, but because it's this sort of negative, people think of winning the lottery is good, and obviously winning the cancer lottery is bad. So I was trying to think of a way to communicate cancer risk, and I thought of it as an old-fashioned clawfoot bathtub with a wobbly leg, and we're all born with a certain amount of water in our cancer bathtub, and there's a leaky tap that we just accumulate this damage that leads to cancer over our lifetimes. And although we can never stop that leaky tap, we can lower the flow by adopting healthy behaviors and avoiding unhealthy behaviors. And how do we know when our bathtub is getting full? Well, we know through screening for various cancers that it's getting pretty full by our 50s. So what can we do to, it's panel with the photos here, the videos. It's never too late, but it's also never too early. So adopting these behaviors, and the reason for the wonky leg is that if you have water in your bathtub that we're all born with, any kind of perturbation can cause that water to overflow, and that's this sort of analogous situation to cancer, which, you know, cancer breaking out from its local environment to cause its chaos. And policy has a role in this in terms of lowering the pressure in the system to stop that the amount of water coming in. So just to wait, but it comes down to it's all probabilities. You know, people say, oh, you know, my grandfather smoked his whole life and lived to 100. Not many do, but yes, there is a probability of that. But we know that the vast probability is that people that live unhealthier lifestyles have shorter lives with more disease. But equally, people who live these perfect lives can be struck down by cancer or disease earlier in their life. So it is a probability, and the best solution we have right now is to follow the recommendations that I've just shown you, that are based on strong evidence.
So the water can never go down?
Well, the screening and, you know, I mean, colorectal cancer is probably the example where when you have a colonoscopy and they take out those polyps, that is analogous to actually removing some water. But it's pretty difficult to remove the water. I mean, what we've seen, if you look at, say, cardiovascular disease, if you stop smoking, I think it's within 10 years, you have the same cardiovascular risk as a non-smoker. We don't have that kind of evidence for the reversibility of cancer risk. It's not to say that it doesn't exist, but we don't have that evidence yet. Even for things like, at least in the laboratory setting, the cancer risk associated with obesity, if obese mice lose weight, lots of things improve, but the cancer risk doesn't necessarily, or in that situation, the tumor formation doesn't reduce. So that is an area that the research is really needed to look at, because there hasn't been that much work done on people changing their behaviors. We know about these as sort of static exposures, but in terms of changing behaviors, that's really where the research needs to be done. But good question. So, as you know, President Biden said that there are few good ways to prevent cancer. We know that about 40% of cancers could be prevented with the knowledge that we have right now, if everyone did it. And that's not to say that if an individual changes their behavior, they won't necessarily get cancer, but we know that as a whole, as a population, and it's maybe unrealistic to expect everyone to adopt these things, but that is the goal. You know, we know we can substantially reduce cancer risk by changing people's exposures, and you know, part of that starts with awareness, and every couple of years we do a cancer risk factor awareness survey, and about half of the people are unaware of most of these strong risk factors: alcohol, obesity, low physical activity, diet. You know, people often think that it's genetics and pesticides and things that actually account for a fairly low proportion of the cancers. So that's.
Could you repeat that?
Which bit?
40%
40% of
are
cancer.
unaware.
Around, it's usually about half. I mean, it differs by each of the risk factors. But for instance, less than half of the population believe or understand that alcohol is a risk factor for cancer, and it's a risk factor for 6 types of cancer. Obesity, it's gone up. I think it's just over half of the population now are aware that that's a risk factor for cancer. You know, it's very high for smoking. Pretty much everyone knows that smoking is a risk factor for cancer. But for the, I think I actually have it here. Grab me some more examples. I thought I had it here. Oh yes, I do. So these change over time. So in 2019, it was 45% of the population understood that were aware that alcohol was a risk factor for cancer. 43% for red meat, that's the highest it had ever been. Only 38% of people realize that diets low in fiber are a risk factor for cancer. Only 10% know about coffee being a beneficial factor. People know that sunlight is bad for you. 82% of people realize that. What else have we got here? Only 39% of people knew that insufficient physical activity was a risk factor for cancer. So being the organization that we are, we have an engaged audience that some of them are like, but we know all this stuff. Why do you keep telling us this? And then we have other people, this, you know, the 40–50% that are like, really? Obesity is a risk factor for cancer? Alcohol is a risk factor for cancer? So there are 2 very different worlds out there. And you know, you're obviously a very knowledgeable audience. But there's a lot of people out there that have no idea. And you know, it's why when you look at the recommendations, you know, when we launched the 3rd expert report, you know, the recommendations, someone in the audience said, so if there's 1 recommendation for weight and 1 recommendation for activity, but 5 recommendations that cover diet, is that because diet's 5 times more important? We're like, no, but it's at least 5 times more complex. If you just say to someone, eat a healthy diet, to some people, you know, a Snickers bar is healthy because it's got nuts in it. So you really have to try and frame it with some structure that, you know, eat lots of vegetables, don't eat processed food, limit red meat, and come back to that. We don't say, you know, never eat red meat, never eat sugar, never drink sugar sweetened beverages, because we do want the recommendations to be accessible and realistic and attainable. Because if they said, you know, never do these things, people would probably just say, well, I'm not doing that, I'll ignore them all.
So
Nigel,
if I could let me moderate. So Amit would be first, but if you could use the raise hand feature if you have questions for Nigel, and I'll call on you in turn. Go ahead, Amit.
a couple of questions. So I assume you are looking at data that is internationally available as well, right? For example, the China study is considered one of the bigger studies related to nutrition and effect on health. There's a lot of work probably happening internationally. So that's question number 1. And second, you said in kind of the 2020s, you guys are looking at the timing of eating. So you haven't talked about fasting, long fasting, intermittent fasting, those kind of things. So if you could comment on that as well.
So first of all, just yes, the data is global. In fact, we just changed the name of the program to Global Cancer Update Program. The China study is a very famous study, but it's the quality of the data is not as strong as it could be. There are some things that we would agree with the China study, certainly the vegetables, but there are some things that are in the China study that are advocated by Colin Campbell and his followers that are not supported by evidence. So just a little caveat there. What was the next question again? Sorry.
Related to fasting, since you said the timing of eating is kind of something that you guys are looking at.
Yeah. So I mean, when you say we are looking at, yes, it is something, it comes under our sort of dietary patterns analysis, because it's not just what you're eating, but when you're eating it. The evidence isn't really strong at the moment. There is, in breast cancer, there's some pretty encouraging results looking at the overnight fast. I think that sort of 14 hours is kind of sweet spot that seems for breast cancer survivorship. I haven't seen any studies in prostate cancer. I'm sure they're probably out there. But I think that is an area, but I think I actually saw a negative study on the ketogenic diet and prostate cancer. But fasting, that overnight intermittent fasting, does seem to be beneficial in breast cancer. I can't comment on prostate cancer, but it's certainly an area, partly because it's relatively easy to do compared to some of these other more extreme interventions. But I think that's all evidence that's going to be coming out.
I've got a question on personalization. One of our big, there are two major thrusts of this group. One is power to the patients, like patients should have more say in the system, which is dominated by institutions. And the second is trying to accelerate personalization. And personalization and the things you've talked about, I was very frustrated when I got my chemo, for example. There was no advice, somebody who's having chemo should do this from a lifestyle or dietary perspective, or you have these particular genomic biomarkers. Subsequently, I got microbiome analysis, thinking that might give me some guidance on things I should do. There's metabolomics, transcriptomics, genomics. What do you see in the frontier of personalization, either because of somebody's being treated with something, because they're, the typical cancer treatments include chemotherapy, immunotherapy, radiation. Are there things that are associated with those treatments in cancer? And are there any other personalizations based on any kind of omics analysis?
So in the cancer survivorship setting, there are various rearrangements that are seen in the genome of prostate cancer patients. The it's a common genetic change that's seen in in prostate cancer cells, and I can't remember the name, but
Temposerg?
Sorry?
Was it Temposerg?
Yes, that's the one. Sorry, I'm not a prostate cancer expert. I've published a little bit in it, but I mean, prostate cancer is doesn't have the benefit of the subtypes, for instance, that drive breast cancer treatment. The personalization, as you indicate, is kind of down to the individual. We don't have strong clinical guidelines. I'm not an oncologist, but my observation is someone's diagnosed, there's now the watchful waiting, which is probably better than the radical surgeries up front. And then treatment, and then I'm assuming that if you're all advanced, that is it all bone metastases that you?
No.
Where, because
Not all, but most, 75 or
nodes.
80% have bone metastases.
yeah, and most of that research has really come from what's worked in breast cancer, but we don't have really good targeted therapies. And I think that where this is going, although it's been very disappointing so far in prostate cancer, I believe is the immunotherapies, but prostate cancer tends to be a very immune cold tumor, or to have the tumors are immune cold, the immune system doesn't respond to them. And I was thinking about this on the way in. There are actually sex differences between the immune system, in terms of males and females. Males, particularly older males, tend to have poorer immune systems. So I kind of wonder how much of, so Rick, I saw you raise your hand. Is that
Older male?
yeah? Well, but I wonder actually how much of the immune coldness of prostate cancers is actually due to its typically in older males. And I'm seeing lots of younger looking males in front of me. Certainly, I don't consider myself old. So, but a lot of these lifestyle factors have an impact on the immune system. And I think where all of these immunotherapies still require they're not magic. They need the immune system to be doing its job. And if the immune system is already compromised, then they're not going to be able to function. I also wonder about the sequencing of chemotherapy and immunotherapy, because chemotherapy is terribly bad for the immune system. So if you're then giving immunotherapy as a sort of last-ditch attempt after you've wrecked somebody's immune system with chemotherapy, and I am not dissing chemotherapy. I am here because of chemotherapy. So, but it is a blunt instrument. My own feeling, and this is, actually it's not sci-fi yet anymore, because with melanoma, they've shown some really good results with the mRNA vaccines as therapeutic vaccines. And that is a way I think we will see, I believe we will see massive progress, because mRNA vaccines, you can pretty much, if you like, 3D print them, just the sequence that you're trying to target. But again, you still need an immune system to put those into use. And these lifestyle factors all influence the immune system. So that's where I think things are going right now in terms of personalization. The way the system is set up, you kind of have to be your own advocate and look at these things that have strong evidence. So I'm seeing some questions down here. I'll just finish my thought. I think one of the things that we struggle with is we have this process to assess the evidence, and the bar is very high, because we don't want to say that there's strong evidence for something if there's not, and if it can do any harm. So we have a lot, when we just did the colorectal cancer analyses, and there was there was a lot of evidence there, but almost nothing that we could make strong conclusions about, because you can always look at flaws in the evidence and say, well, they haven't accounted for comorbidities, or whatever the factor is that reduces your your confidence in that conclusion. But we're in an information landscape, excuse me, where people are making all sorts of outrageous claims about things that have, never mind, no evidence, no research, just, you know, a product and a claim. So, you know, we stick by, if you like, this conservative approach, and it's arguably overly conservative. But then knowing that these factors can have a benefit and there is a low risk of harm, that's why we take the approach that we do. So let me get down to these questions in the chat. Or do you want to do those, Brad?
Rick, why don't you give voice to the questions you put in the chat, please?
Okay, we all have metastatic prostate cancer, so we're beyond the risk phase. So we can't lower the water, but it seems like, well, we can stop the water from getting more full.
Yeah.
But we already have a lot. We already won the lotto, unfortunately. So from what I can discern relative to us is maybe a hope that's a little more aggressive than your conservatism, which would be, okay, I'm gonna at least get my diet and, you know, slow down the water. So
Yeah.
what can I do? I can't do everything that's gone to pass. So
Yeah.
I can work on my weight, my diet, my waist circumference, my intermittent fasting. That's about all I can do. Is there anything else?
So those are the things for which there is, and unfortunately, I can't even say strong evidence in the survivorship setting, but those are things that we believe are beneficial. That is why we have an overall recommendation to follow the cancer prevention recommendations. You know, not only will it impact or potentially impact your prostate cancer progression, but all of those other factors. You know, if you've, you know, I have heart failure because of the chemotherapy that I received in my late teens and early 20s. If I hadn't been physically active all my life, absolutely certain I would not be here. So, you know, the treatments that you receive are not, they're good for the, you know, for the cancer, or they're bad for the cancer, but they're also bad for the rest of your body. And it's so the more you can do to maintain your resilience, the better place you'll be in. I'm seeing this thing about starve the cancer. Your ability to actually do that is negligible, because cancer cells do have a greater affinity and demand for glucose, but you can't take. There are certain clinical situations where that is feasible, but there are few. You know, the fasting acts on a more sort of metabolic level, but trying to sort of starve out your cancer, that is not going to work. I see. So you take all of them. So what treatment are you on? Active treatment, Rick?
Yes, Pluvicto, and I just started abiraterone again this morning.
Right. So those are bone targeted, aren't they? No, abiraterone.
It's a hormone therapy, and the Pluvicto is a radiation targeting PSMA.
Right. What we've seen in other cancers is that some of these supplements can actually interfere with the action of the treatments. And the way I look at it is, you can't kind of have it both ways. You know, if these supplements are powerful medicine, then they can do harm. And if they're not powerful medicine, then what are they actually doing? So
I believe they're anti-inflammatory is the concept for most of them.
yeah. I mean, resveratrol was certainly originally looked at because it was related to telomere length, but the evidence is, I mean, turmeric, there is some evidence it's not, and that has a sort of anti-inflammatory impact. But yeah, there isn't strong evidence for any of these. That if people choose to take them, then but I guess that's why I said at the beginning, I suspect that I might be managing expectations. Yeah, there are pros and cons to all of these things, I think.
What can you say more about exercise? You've referenced it a couple of times, and one of the ways we know is that exercise does enhance your immune system. Is there anything about exercise, because that's a very broad topic? You could be in the gym lifting weights, or you could be running and working on cardio. Any, and it could be a little bit here every day. It could be walking.
It's often said that if exercise was a pill, we'd give it to everyone. Yeah, as long as you are capable of doing it, that is probably one of the strongest medicines that, and it's evidence-based. I mean, we don't have great evidence yet because of the problems of the way this research is done. It's really difficult to eliminate reverse causality. So it looks like people are doing better because they're exercising, but is it because people are exercising because they're doing better? But I would say the overwhelming evidence is that it's beneficial. For, I mean, in breast cancer, when we did the analysis, that was one where we got strong evidence for quality of life. You know, people, and those were all based on randomized trials, and that's one of the few settings where we had those randomized trials, and lots of them. So massively beneficial for quality of life. In terms of the immune system, Ricky Simpson, University of Arizona, has done lots of work showing that every bout of exercise increases the release of immune cells, and they're actually using this in bone marrow transplants now to try and increase the number of cells that can be harvested. So yes, physical activity, if you're able. You know, I've had this discussion with various oncologists, particularly a colleague. I used to be in Calgary, and he considers me an extraordinary responder. You know, who are those people that, you know, really shouldn't be around? And I've been physically active even through my treatment. I used to sort of hibernate for 3 days after chemo, but then would be back to riding my bike. And it's physical activity, and it doesn't have to be exercise, but just being physically active, avoiding sedentary behavior. You know, they make you sit in a chair. Well, I mean, I was 3 days inpatient infusions for chemo. So just going through cancer and sitting waiting in waiting rooms and things is, you know, you have a fair amount of sedentary time. But I think breaking that up, being active, that's huge.
Thank you. Brian?
Yeah, so 2 questions. And Brad kind of alluded to this, but there's a lot of different types of activities. Is there any evidence that would suggest, for example, more vigorous activity is more beneficial? So we talked to somebody recently who, you know, had indicated that he had research that if you burn 1,000 calories in a workout, which is a lot, I mean, that's 1,000 calories that's significant, that it can be meaningful in in helping to keep your cancer in check or maybe even improve your condition? So that's the first question. The second question is, with all of the devices that we now have to track activity, generating a whole bunch of real world evidence, how is that getting integrated into our research? So 2 questions.
I'll answer the second one first. The frustrating thing is that all of that, the Garmin data, the Fitbit data, that all is not being used as widely as I think or hope it should be. Just even looking at COVID, I know I ride and I do indoor rowing, and I have a lot of friends who have had COVID and then experience significant deficits in their fitness and performance. But because they track their behaviors and they're motivated, they're trying to train back up to it. But I think a lot of people will just think that's their new normal. And I think there's going to be a step down in the sort of population level physical activity. The linkage between cancer and that kind of data, they're all individual studies. And it would be great if someone could do like a registry linkage with people who are using those devices, because there's huge data resources there. I think there are privacy issues that get in the way of it. People would have to opt in, and there's also probably a bit of there would be a skewing towards those people who are more active, certainly at the moment. But I think mobile phones give us a pretty good, most people carry their mobile phones on them, and there's a whole potential there for that kind of movement data, but we're not there yet, unfortunately.
Okay, then what about the other question, the first question? I mean, in terms of like
so in terms of intensity,
yeah, intensity.
So it depends on the purpose. If weight loss is a goal, then probably a mix is best. People are usually, if somebody is completely sedentary, then the first advice is usually walking or some sort of low and slow type of exercise. The immune benefits seem to come more from the high intensity HIIT type workouts. This idea about aerobic exercise lowering the immune system is probably false, and comes from research that was really from mass participation events, where it was talking about people who get more infections after a marathon, etc. And it's probably more the fact that they're mixing with lots of people rather than the aerobic exercise itself. So I think all exercise is probably, unless you're overdoing it, there is evidence that very extreme, because the immune system is quite an energetic process. If you are overtraining, if you like, that is some way you could reduce your immune system. But I think get active, high intensity, at least some high intensity, seems to be more beneficial. The role of weight training is, in terms of strength resistance work, it's been studied, but I'd say the results are less compelling. But I also think that there was a trend to, a lot of the research was done on aerobic exercise or activity, and then, oh, well, what if we add in strength? And it's only relatively recently that the high intensity studies have been done, partly because people a long time ago, or not that long ago, 15, 20 years ago, people did not think that cancer patients should be exercising. And oncologists were very protective of their patients. And this is in the dietary advice as well. You know, historically, cancer patients, you know, very toxic treatments, got sick and skinny. But that was, you know, before we had 70% of the population with overweight and obesity. For some cancers, that cachexic effect, that wasting, is still an ever-present danger. But for breast, probably for most prostate cancer patients, the bigger problem seems to be weight gain.
Okay, we are sort of over time here. Eric had a question, his hand was up, but now I see there's a question in the chat, and Amit has a question in the chat. Could you just respond to those really quick, Nigel, like rapid fire, and then I'll stop the recording, and then if people want to stay around, we can talk more.
So there's a question about exome sequencing, right? So I used to do a bunch of work in head and neck cancer. And in 2012, we were writing this big sort of programmatic grant to try and do what had been done in breast cancer over 20 years in 5 years. So basically identifying those targets and then screening drugs to try and target those particular features in tumors. And we were at a conference where everyone was trying to do this. That was 2012. 2016, we didn't get funded to do it. And as hard as that was at the time, went to the conference in 2016, and it was basically the whole field of head and neck cancer saying, that didn't work. Because yes, you can find these changes, you can target them, and you get the odd extraordinary responder. There are lots of these personalized oncogenomics programs around the country, around the world. But typically, if you are just going after one target, cancer finds a way around it. So you may get a really nice response straight off the bat, but then, you know, the redundancies of these things. And I think that's why the immune system is so important, because then you're using a system against a system rather than one tool against one target. So I think the corollary of that is, or the kind of exception to that, is lung cancer, where, you know, there has been great success, but again, they're relatively short-lived. But in lung cancer, where survival was so short, those are, you know, if you're doubling somebody's survival, but that may only be taking them from, you know, 3 months to 6 months, or maybe 6 months to a year. But the problem universally with those sort of targeted approaches is resistance tends to develop.
Okay, the last question is Amit's then on the sort of the funding aspect of this in this area.
So we fund research, obviously. We've got a few prostate cancer grants. One of them is actually looking at the role of coffee in trying to reduce progression on people on active surveillance. But yes, these are expensive studies. The size of the effects tends to be fairly modest, so you need a lot of people. And there are, you know, these are not areas where pharma has been typically very interested. I do believe, and I know I keep going on about the immune system, but I do believe that in the near future, the role of lifestyle in assisting the immunotherapies is going to put these kind of exposures front and center. But yeah, there is a relatively small community of people and a relatively small funding envelope for this kind of research.